Thanks very much for that, Mo. My name's Emma Wong. I'm a GP in Sheffield. Are we doing... Fantastic. So I've got something different on my screen here. So I'm introducing Chris Probert, who's a Professor of Gastroenterology in Liverpool with a specialist interest in IBD, Crohn's and celiac. Unfortunately, he can't be here with us today, so he has recorded his talk, but he will be available for questions afterwards. I think he's remoting in, so over to the technology.
Hi, hopefully you can hear me. This is Chris Probert calling from Liverpool, and I'm a gastroenterologist, and I've just stepped out of an IBD clinic in order to give a talk for you today. I'm afraid our service is under pressure and I couldn't take the whole morning off, so sorry I can't be there. I've entitled my talk, Protect Your Patients from Calprotectin, and hopefully you'll see why in the next few minutes. These are my disclosures. The ones in bold apply to the last 2 years during COVID. It's been a quiet time for talks and so forth. So, as you may have heard from Mo, calprotectin is a stool test that we use, and you should know that it's a protein that is found in neutrophils. This protein is stable in feces, and it's stable at both 4 degrees and at room temperature for days. Now, this means the patient can collect the stool sample in the privacy of their own home and send the sample in or take it to clinic when they attend. I always say to patients, we don't expect them to give a sample on demand. It's not like giving a blood test or a stool or a urine test. So calprotectin was initially a niche test for specialist IBD centres when we were monitoring IBD. And it's quickly rolled out from specialist centres to all hospitals across the UK. And now it's available to GPs and now even to patients as a point of care device. So in the future, with more remote working, you will have patients testing themselves at home. My advance didn't work there. So what is the normal level? This is a very important question. In Liverpool, when it was launched, the cut point was 50, and then we've tried to move the level up to 150. And in negotiation with our GPs, we said, well, between 100 and 200, let's repeat the calprotectin test before you consider referring the patient. So repeat. If it's over 200, then please refer on an IBD pathway. Around the UK, I know that other centres have different cut points. In Newcastle, for example, I'm told it's 200 and Glasgow 250. So there's some controversy about the cut point, but clearly 50 has been too low because we've had a lot of patients referred to us with the raised calprotectin, 50, 60, 70, and really that isn't abnormal. And we then have to explain to patient what's going on. Now, I'm not going to criticise that, as you'll see later. It still has a role in the referral pathway. So how should we be using calprotectin in primary care? Patients with IBS wait too long to be diagnosed because of diagnostic uncertainty and a lack of a biomarker. NICE has said use calprotectin in patients to help rule out diseases with similar symptoms. In other words, probably inflammatory bowel disease versus irritable bowel syndrome. And for me, that mainly means Crohn's disease, UC tending to be painless. But a recent study in primary care found that roughly 48% of patients who had a normal calprotectin was still referred. And we'll discuss why that happens in a moment. My advance hasn't advanced, I'm sorry. There we go. So in primary care, we should be using calprotectin to triage referrals. In younger patients, I'm going to suggest under 50, with chronic diarrhea, more than 6 weeks, calprotectin is a useful test, particularly when pain accompanies diarrhea. Without pain, we shouldn't be diagnosing irritable bowel syndrome. Functional bowel diarrhea, perhaps, but not IBS. And in those patients, of course, you're going to consider celiac serology and always look at the drug side effect profile. In my clinic, I see a lot of patients taking SSRIs with diarrhea and lansoprazole with diarrhea. So there's a lot of side effects to consider. Be wary of patients with acute presentation. Gastroenteritis and anything that bleeds can put up the calprotectin. So I've had a patient with some granulomas, granulation tissue on a stoma, for example, that was bleeding, calprotectin was raised. Hemorrhoidal bleeding, calprotectin will be raised. So be a little bit wary and don't give it as a test to people with acute diarrhea, because the infection will give you white cells, will raise your calprotectin result. In secondary care, this gets quite interesting. 85% of patients who were referred to secondary care with suspected IBS still undergo investigation with scans and colonoscopies. And thinking about this, 47% of patients with negative calprotectin and our approach in some clinics to investigation just makes you wonder what's going on. Part of this is patient pressure. They had a friend with a misdiagnosis. They heard about the blogger with cancer in their 20s or 30s. They don't believe IBS is a diagnosis, or they've had treatment for IBS that's failed, and they therefore question the diagnosis. And that generates anxiety in the clinician, primary or secondary care, leading to tests to reassure. And often doesn't reassure, it exacerbates anxiety that something has been missed. People also investigate where they consider the calprotectin to be equivocal. Instead of repeating it, they've just gone straight for a scope. I would say lab noise can be an issue, a little bit of anemia, maybe a slightly raised CRP from obesity. All those things might make you investigate patients when it's not really necessary. And I think we should use calprotectin data wisely. And it's much better to repeat a calprotectin test than just book a scope. There's huge pressure on services, and of course, as you've heard, it's dangerous in some situations to do the scope, and so let's not do it unless we need to. Some of the premise of my talk is calprotectin can be a useful guide, but it can be a burdensome red herring with potential to lead to over-investigation and misdiagnoses. I don't think we collectively are using it very well to diagnose IBS. I think we're possibly over-reliance on it to diagnose IBD and response to therapy in IBD. And we're over-investigating patients with a raised calprotectin. So I said that to set up some controversy. So a couple of cases for you. This is EB, a 28-year-old woman with a long history of pain and diarrhea, who was investigated at St Elsewhere's and thought to have bile acid diarrhea and possible IBS. The calprotectin was marginal between 200 and 300 on a few occasions. And so she wound up seeing the local national expert on IBS, who doubted the diagnosis and felt a new opinion was useful and referred to me in Liverpool. With a full service, I didn't get to see her for a while. Consultant number 1 was reticent and repeated the whole cycle of investigations. A patient came back to see consultant 2, who then requested a capsule endoscopy. That was reviewed by consultant 3, who felt a diagnosis was not secure, but noted the calprotectin was still up a little bit and gave the patient a trial of budesonide. So then I got to see the patient, and I noted that the diarrhea had improved with budesonide and decided we should repeat the cycle because symptoms had flared. We would do calprotectin at the beginning and the end, and we would do a capsule in the middle of all this. And we can see here how the calprotectin was very high and came down with a bump on the budesonide. And beg your pardon, wrong click. And on the capsule, you can see a lot of small bowel ulceration. So we took this back to the MDT and said, on the basis of the clinical response and the ulcers that we're seeing, are we happy? And we were. And she was commenced on ustekinumab, and her diarrhea has gone from 30 times a day to once a day with an all stool. So that borderline calpro was investigated at length. Because it wasn't terribly high, people kept thinking this must have been an IBS, but we got there in the end. Next patient is quite straightforward. So 29-year-old, last April in COVID, was admitted with 3 months of bloody diarrhea, bowels open a lot, CRP up, calprotectin up, and was scoped, had acute UC, and was given hydrocortisone. After 3 to 4 days, there was an inadequate response, still opening the bowels more than 8 times a day, and the patient was rescued with infliximab. And we can see the calprotectin was super high. It came down, and it's bumbling along quite nicely now. And when I saw the patient last month, the patient was very well and maintained on one of the mesalazines and infliximab. We thought it was time to stop the anti-TNF. The patient had been on it for a year, had a gratifying response, no further meaningful relapses, and was now on suitable safe maintenance medication. And we're going to be using the calprotectin in a remote clinic to monitor this. Now, we have a patient-initiated pathway. That means that patients who seem to be well are given access to the clinic if they have symptoms, but they are monitored with a questionnaire and calprotectin at intervals in order to meet demand and also satisfy patient expectations that COVID has told patients they can be monitored remotely. And we need to do that safely, and that's how we're going about that. Third patient is a little bit more challenging. He presented to a colleague last summer with a 15-year history of Crohn's. He'd had a resection and reconstructive surgery and failed some anti-TNFs. And when imaged last summer, there was a 11-centimeter stricture with some pre-stenotic dilatation. And my colleague decided to give the patient vedolizumab, having failed anti-TNF. And you can see here that actually the calprotectin had been raised in the past, but last summer was actually normal. And so the choice of vedolizumab was a little bit questionable, given that although there were symptoms, there was no inflammation. And what happened, the patient tolerated the pain and symptoms a little bit longer and then ended up being admitted in April. Again, the calprotectin was normal, there was more imaging. And really and truly, this is a patient with progressive stricturing Crohn's disease. There wasn't a burden of inflammation. Arguably, the vedolizumab was the wrong thing to do. And the calprotectin, which was thought to be misleading, reassuring, was probably actually telling us that this was not an inflammatory process and the patient should have had a referral for surgery or on the waiting list despite COVID. So I would say in this situation, the calpro told us the patient needed to have a surgery rather than another drug. So calprotectin is not the whole story. A falling calprotectin might tell you the disease is coming under control, as illustrated by case 1 and case 2. But in the third patient, there were symptoms and a normal calprotectin. And I think this tells you that the inflammation was not the cause of the symptoms. And really and truly, this should have been an alert to surgery. And in fact, it was misleading to the person looking at the data. So you need to be quite wary how you look at the data and think about the whole situation, as illustrated by the next patient. So this is a patient who is now 47, who had a 15-year history of colitis culminating in a colectomy and an ilioanal pouch. At the start of COVID, she had worsening diarrhea and weight loss. And my colleague, it's always my colleague felt that this might have been Crohn's disease after all. She'd had some post-op problems, so just maybe the diagnosis was wrong and now there was a problem. And did a calprotectin, and that, of course, was raised. So with the background, she was investigated, and you can see the calprotectin here, and he arranged an MRI of the small bowel. Click. And that was completely normal right down to her pouch. And then, of course, she had a scope. And for those of you thinking this was pouchitis, well, I'm afraid it wasn't pouchitis. The pouch was really very healthy. But there was a little line of ulceration along the suture line. And the learning point here, amongst many learning points, is that where you have an anastomosis at any point in the intestine, there's quite frequently some ulceration. We saw this in the old days of ulcer surgery. and there was always an ulcer at the gastroenterostomy, and sometimes these patients bled and became anemic. And what we're seeing now are anastomotic ulcers where you have Crohn's resection, or in this case, a pouch resection. So you get an area of ulceration on the anastomotic line, and that inflammation is accounting for her calprotectin. Just intermittently, it's bleeding that little bit, but there's no other problem in this patient. And the danger was that we might have run away with the diagnosis of, oh, it was Crohn's, and now you're on to the biologics. So she has not got Crohn's disease. In fact, we went back in, and there's just a hint of narrowing of that anastomosis. And you'll be aware that sometimes a narrowing in this way can cause a diarrhea, which is a paradox that the surgeons understand better than I do. But having dilated that, the diarrhea improved. So how should we be using calprotectin in primary care? We should use it to triage our patients, to stratify our patients. Those with chronic symptoms who are younger, do a calprotectin. If it's equivocal, then repeat. If the result is going up, refer. If it's going down, you can be reassured, sit it out. Was it infection that led to the presentation? Don't forget that any bleeding will make the calprotectin go up. So if the patient, as they do, is taking a non-steroidal for any reason, but maybe even for their stomachache, that might give you small bowel ulceration, that might then give you a raised calprotectin. So just be wary about that level. If it's going up, we want to know about it. If it's going down, be reassured. Also in primary care, it's going to be used increasingly to monitor IBD by patients doing home testing. At the moment, most of these kits are binary, raised, not raised, but they're going to become more quantitative. I would say a learning point for primary care here is that the results rarely normalize. They may come down to normal. It's nice when that happens, but all we're really looking is it going from 1,000 to a couple of hundred? It won't necessarily go to less than 50, and we shouldn't be pursuing that exhaustively. We want it to come down, but don't expect miracles. And what about in secondary care? Again, we can use it to help triage patients for investigations, to stratify and monitor. And I would emphasize always that the calprotectin is a nicer test for the patient than a colonoscopy. Though in the past I've had patients in whom I said, well, I'd quite like a stool test, and they say, oh, we don't like that. It's a bit gross. I really don't want to do that. To which my reaction is, that's absolutely no problem whatsoever. Shall I book you a colonoscopy? Whereupon they all say, I'll do the stool test. It's not the nicest thing for anyone to do, but it is better than bowel prep and a scope. Look at the trend. If the levels are going up, then we're under-treating the disease that we're trying to identify. We've identified. If it's coming down, we're doing something right. Listen to the symptoms. If there's a disconnect, ask yourself why. Okay, the patient's got pain, the patient's got diarrhea, but the calprotectin is normal. Is it because they've got a stricture? Is it because they have the IBS-like symptoms of some patients with inactive IBD that we now recognize are more common in patients with IBD than in the normal community? So IBS-like symptoms when the IBD is in remission are quite common. And the calprotectin there is useful to help you identify those patients. But don't forget the strictures. Not every normal calprotectin is IBS. There are false negatives. There are patients with a little bit of isolated small bowel disease that might be missed. There's bacterial overgrowth that might cause symptoms, and there are strictures that might cause symptoms. So always think what's going on in the patient. Not every raised calprotectin is raised. As I've said, it can be an IBD, it can be an anastomotic, it can be a polyp, as Mo has just told you. They will bleed, and we're going to be detecting white cells because there's bleeding. So cancers will also put up calprotectin. So how should we protect our patients? Well, it's useful. It's transformed the monitoring of patients with IBD. We no longer have to do X-rays, CTs, scopes as often to monitor response to treatment. It should aid our diagnosis of IBS if we use it wisely, and also help us make a more rapid diagnosis of IBD. We know many patients are told they've got IBD before they're told they've got IBS. It works both ways. Most patients would prefer to give a stool sample and have a scope. But please remember, no test should be used without careful consideration of the patient's situation. Never take the data in isolation. Take the big picture and try and use the test wisely. And with that, I believe I've finished. Thank you very much for listening to me.